with the introduction from Dr. Lalit Verma to this course on treatable macular disorders, which we've been continuing for many years now in the IOS.
You all know that macular disorders are one of the commonest. In fact, in a specialty practice, if I analyze my practice, more than 40-50% patients are macular disorders. And even if you see general ophthalmology practice, there is a substantial number. And the reason we started this course was because of advancements in diagnostic technology, OCT, Octa, so many things have come up. There has been a shift in diagnosis also and management also. So instead of giving, controlled studies, what I have done this time is to have my approach in 5-6 common conditions. You can't cover everything. My approach to CSR, my approach to CNVM. Once a patient comes, what do you do? You take him to the camera, you take him to the Octa machine, you take him where? And after that, what do you do further? So basic aim was to offer to the patient the best possible diagnostic as well as therapeutic. So I have, lined up a very nice faculty with Dr. Raju already here. So we will not go into all the studies and what, RCTs have told. We'll go that he will tell what is CSR and how do we approach this. So with this, I think we'll start, and we have Anand, Dinesh, Mallika, everyone, who will tell about the common disorders, which include CSR, CNVM, DME, RVO, and macular hole. Macular hole also I have not covered the routine macular hole. I have listed my extra large macular hole, because the definition of small macular hole is 200, large macular hole is 400. Whatever practice we get all 900, 1000 to 1400. So how to approach them? Because the conventional management may not succeed. So therefore, we have taken only extra large macular hole. So with these few words and with excellent faculty here, we'll start and request Raju to start.
Yeah. Thank you very much, sir. Thank you for giving me an opportunity to be a part of your IC. Pranams to my teachers on the dais and the audience. I'll be sharing with you how I would treat a chronic CSR with a central leak. It's a very focused topic that sir has given me. Well, we all know that CSR is the fourth commonest non-surgical retinopathy associated with fluid leakage, and it was termed as central recurrent retinitis and later termed as central serous chorioretinopathy, letting us know that the choroid is also involved in the pathology of this disease. Most cases of CSR resolve, but however, some become chronic, leading to persistent visual problems, RPE atrophy, and recurrence. But what is the definition of chronic CSR? Actually, it's very confusing. If you go by this classification, they are classified as non-resolving CSR, recurrent CSR, chronic CSR, and inactive CSR. And non-resolving or persistent CSR is classified as something that is lasting more than 4 months. And the chronic CSR and persistent CSR, again, they have made a differentiation. Chronic CSR is only when you have a widespread RPE atrophy or with neurosensory retinal detachment. So they have made classification between, again, chronic and persistent according to this study. And when you go back and see the various studies, each study has taken a different criteria. So how do I classify my case as a chronic CSR? Most studies have taken it as 3 months. And probably persistent cases and chronic cases are all clubbed together. So there is a lot of confusion in the terminology itself. So to overcome this, the Central Serous Retinopathy, Chorioretinopathy International Group published the criteria for CSR into major criteria and minor criteria. The major criteria are the presence on evidence of prior SRS and at least one area of RPE alteration on fundus autofluorescence or on OCT or infrared imaging. And they also had a minor criteria, which is on ICG or FFA leak being present and choroidal thickness. So these are the various criteria that have been proposed to maintain uniformity in our diagnosis. So now they have classified CSR as simple and complex and atypical. And again, From there, you are again subclassified as primary, recurrent, and resolved. And anything where the SRF is persisting more than 6 months is now called as persistent. Now, all of them can be associated with RP atrophy or with a CNVM. So this is the current classification to maintain uniformity across all sectors, all studies. They have proposed this classification, and probably we may have to use this classification going forward, which means to say that persistent is the one which would be termed as a chronic CSR. So this is how it will be. Classification would be a simple CSR and a complex CSR. Persistent is the one which is more than 6 months of SRF being present, with or without RP atrophy or with or without CNVM. This would be the new terminology. Now, how do you manage these cases? So now again, we have to go back to the pathophysiology. This is the basic pathophysiology that we are all very much aware of chronic CSR, wherein there is a choroidal thickening, vascular congestion, altered blood flow, and choroidal hyperpermeability. Now, this is what, as a basic, we started. But if you look at it, this is a very busy slide. So this is all the various pathophysiology that can be involved in the CSR, and we may have to look at all these things because it is a chronic CSR now, not acute CSR, because we may have to rule out each and everything. And probably most of the times we are looking at this aspect wherein the corticosteroid induced or stress induced is the one that we are looking, but there are various other causes which might be leading to CSR. Now, that's why we need to take a good history. So the good history includes you need to rule out the use of any drugs, then look for endogenous and exogenous causes. Some other causes like sleep apnea has to be considered. The end-stage renal disease also is one more disease which can lead to a chronic disease. Cushing's disease, again, can be a first presentation of CSR, and that should be ruled out. Then, in these cases, we may require additional tests. So, chronic CSR patients, I may consider doing a serum cortisol levels, testosterone levels, platelet function tests. Sleep studies I have not yet done, but may need to consider them. As far as the additional tests, ocular tests that are concerned, we may have to do an enhanced depth OCT, then ICG and OCTA. These are the three investigations that would be required in these cases. Another thing is a good clinical examination. This was a case referred as non-resolving CSR and ended up actually having an optic dysplate. So the OCT will give out the diagnosis, but you need to look for the optic dysplate in these cases whenever you suspect a patient of persistent CSR. The typical ink blot leak and the smokestack leak is not seen in these cases. These cases usually have a more diffuse disease with lot of RPE atrophic traps, and hyperpigmentation and hyperplasia may be seen in these cases, and gravitational teardrop and hourglass shape you may see on the FFA and OCT. In the OCT, again, you have a very diffuse disease, a shallow or a flat PED will be there, then hyperreflective detached photoreceptors may be seen underneath in the lower part, the outer retinal layers. And very chronic cases, you may see thinning. Autofluorescence actually gives you a better picture, showing you a wider range of the disease activity, and especially the shortwave, the infrared is better than the shortwave conventional FAF. Enhanced depth, again, you'll be able to see the increased depth in the increased thickness, choroidal thickness, and ICG-A is one investigation that I would like to get it done in these cases, wherein we can see that mid-face hyperfluorescent plaques will be seen in these cases, and OCT-A can pick up this macular neovascularization, which can be leading to chronic fluid leakage in these cases. We may also have to rule out PCV in these cases, which may mimic something very similar to chronic CSR. The aim of the treatment would be complete resolution of SRF, preserve the photoreceptors, improve visual function, and prevent recurrences and disease progression. So we always look at some treatment options that includes the psychotherapy, then the pharmaceutical treatment and the lasers would be used in these cases. As far as the medical treatment is concerned, most likely we'll be using the eplerenone in these cases. The other mainstay of treatment would be the PDT and the lasers. So this is how we usually treat acute patient comes to us with CSR. Most of the times we observe these patients for about 4 to 6 months. If most of them would resolve spontaneously. If they don't resolve, then I would go ahead and do an ICG and Octa in these cases and rule out a CNV and then plan accordingly. So this is how we would look at. So observe for 4 months. If this is not responding, then we go ahead and do the ICG in these patients. ICG and Octa would be required. Okay. So as far as treatment is concerned, previously when we had the availability of PDT, half dose vertiporfin PDT was better than subthreshold laser according to the studies, and this is now not available. Then when compared with eplerenone, again PDT is better. But however, the PDT had these risks. If anybody has access to PDT, then this is the best treatment that is available for these patients. As far as micropulse laser is concerned, this is to be done in a targeted way for the hyperfluorescent areas that are seen on ICG. Some of us also paint the whole CSR area using this duty cycle of 5% and pulse duration of 200 milliseconds. And this works, is said to work in about 17 to 20% of the patients. However, what they found was there's no influence on disease recurrence and no difference to the choroid was seen with laser photocoagulation. As far as antioxidants are concerned, again, did not show any benefits. However, the fluid reduction happened slightly faster with antioxidants. Eplerenone, again, we all been using it with success. I'll show you my cases, but this was not found to be superior to placebo. So eplerenone was no better than placebo. So these are my few cases wherein this was a patient who had an exudative CSR kind of a picture for 3 months, and treated with eplerenone, he responded quite well. This is another patient who responded to eplerenone. Most of the cases I had started with eplerenone to begin with due to lack of access to PDT, and he responded to eplerenone, but however, he came back later with a detachment again, which was found to have a CNV or a macular neovascularization, and this was treated with ranibizumab biosimilar. However, he continues to require injections on and off in these patients. There is one more patient treated for MNV. So the take-home points is that we may have to adopt to the newer classification, and the CSR will have these atrophic changes. We need to look for this, and multimodal imaging would be the mainstay of treatment to help us to find out the PCV, rule out PCV, and to find out a macular neovascularization. So the best option would be still a vertiporfin, which is not available, and the other two options that we have in our hand are the micropulse laser and the eplerenone, and for chronic cases with MNV, anti-VEGF injection would be required. Thank you.
Do we
Thank
have
you,
any questions from the audience?
Thank you, Dr. Raju. Yeah. Any questions from the audience? Yeah.
Usually, to begin with, we start with 25 mg and look for hyperkalemia. So before you start the patient, you do electrolytes, serum electrolytes, and look for hyperkalemia. Then if he's tolerating, I increase it to 50 mg. Then continue it for around 1 to 1.5 months. Then try to taper it if the patient is doing well. Then get him off. So usually around 2 to 3 months is what I usually would give.
Yeah, but the basic problem with eplerenone is when you taper it off, it often comes back. So, and this is the problem with all the other things also. Even rifampicin, say it works in some cases, yes, that's anecdotal. You stop the rifampicin, it comes back. So this is not the answer really.
But it can be used for several months. To answer your question, it can be used up to a year or two also, if the patient is able to tolerate.
And the only thing is that this toleration requires a constant check on hyperkalemia. So you have to have a serum electrolytes done on a at least weekly, 2 weekly basis to make sure you don't end up with a problem there.
So, like, why this PDT not available nowadays? Like in all CSR sessions
It's not,
we hear it's
PDT is off patent.
It's not, the Novartis company
So-
has stopped manufacturing Visidoin.
So they don't need to do, and
No,
There
no,
is a
Vis-
yeah, but
global
as of
shortage of
now,
Visidoin.
as of now, there is no Visidoin available. I think there's a localized stock available with Arvind.
No,
but,
no, no, no. In Coimbatore, people are sourcing it from the Middle East, but that's and that also there is some company in Germany, I think Chapla Pharmacy or something, but it's a very vague route of procurement of the Visidoin. It's not Visidoin. Actually, it's a different drug
Yeah,
completely.
so as of now, that's not available, but keep in mind, see, every CSR does not need intensive treatment. If your patient has 6/6 vision, you don't have to be very aggressive on that. It's going to be a long-term disease. Giving treatment which is not going to alter the course doesn't matter. I mean, I have patients who've been there for years without treatment. You're talking of years with treatment, I'm talking of years without treatment. Vision is 6/6, you leave them alone. You don't have to touch them. It's the reason for touching and my indication for touching is if the patient has intraretinal cystic cavities in the macular area. These patients respond to treatment. They respond to anti-VEGF treatment. Similarly, if these patients have fibrin deposits, what looks like Shrem, this is not a CNVM, it doesn't show up as a CNVM on OCT angio, but that is an inflammatory component which responds to anti-VEGF. So other than a CNVM, which is another factor which can happen in these patients and which definitely needs treatment. These are two other situations in a chronic CSR where I would consider giving an anti-VEGF. And I find Eylea works better than ranibizumab for this situation. Would you like to?
Put things in perspective, one option which you mentioned is subthreshold micropulse laser. Now this is breaking up that laser beam into smaller parts, and I'll probably briefly touch upon that in my talk too. So that you're not doing any RP thermal damage. Okay, so this is photosensitization. So that is a modality which can be used, and we've used quite successfully, and he showed that publication also. I'm part of that SOLS international study group. So that is a very viable option. Another option, left field option, is if you have extramacular, and I'm repeating that, extramacular. Another option is titrated low dose transpupillary thermotherapy, which is basically using your red laser, 8-10 nanometers. Okay, the only way where Dr. Dinesh Talwar was saying about anti-VEGF, there's a lot of discourse about that. The way situation where it can work, the reason for it being working is choriocapillaris ischemia is caused in chronic CSR. So that component can be cut. But whether anti-VEGF is a panacea for CSR, answer is no.
Also, I would suggest an OCT angiography at first visit to rule out CNVM, because then it would respond very well to anti-VEGF. So OCT angio, if it is accessible, should be done for every CSR at first visit to rule out CNVM, which would respond to anti-VEGF very well.
thank you.
Hi, how are you? Thanks for coming. It can be tried, but that would be anecdotal response. But it can be tried and it may work.
Some patients respond well. We give 125 milligram acetazolamide in 2 doses for 2 to 3 weeks. They respond well.
Yeah, that's what I'm saying. It's anecdotal, yes. It can.
It's not definitely proven by any level 1 evidence.
But it can be tried in the
Anecdotally,
absence
you
of
may
PDT,
consider,
yes.
but not really. Yeah, can we move on in the interest of time?
Yeah.
Please. It's a pleasure
Good morning,
to invite
ladies and
Dr.
gentlemen.
Dinesh Talwar. Yeah.
We now come to subfoveal CNVMs, including age-related macular degeneration causing CNVM. This is my disclaimer and financial disclosure. See, exudative CNVMs, subfoveal CNVMs, not a single disease, not even in AMD. Even in AMD, you have the predominantly classic, the minimally classic, the occult. The occult itself has 3 different varieties: the late leakage from an unknown source, fibrovascular RPE detachments, and serous RPE detachments. In addition to that, you have myopic CNVMs and inflammatory CNVMs, which can behave differently. Now, the good thing was that the Marina and Anchor studies showed us that monthly regime of treatment with ranibizumab is very effective not only in preserving vision, but in improving vision in these cases. However, this is an extremely intensive way of treating the patients and is exhausting for both the patient and the doctor. Fortunately for us, today we have a large therapeutic armamentarium, including ranibizumab, bevacizumab, aflibercept, brolucizumab, and faricimab. And we also have multiple treatment protocols for exudative AMD and other types of CNVM, including in addition to the monthly injections, you could have quarterly fixed injections or PRN or treat and extend. Over the last few years, treat and extend have become an increasingly popular approach because of its safety. However, how you treat a patient also depends on what kind of CNVM you have. Even today, for me, for type 2 CNVMs, the treatment of choice is not aflibercept, but ranibizumab. For type 1 CNVMs, I believe aflibercept is significantly better than ranibizumab, and that's the way I start. Faricimab, I use in patients who don't respond to aflibercept, and it can help you to extend the treatment interval by 2 to 4 weeks in those patients who are recalcitrant to treatment. And for me, brolucizumab, though it's more effective in drying fluid, but because of its lesser safety and significant lesser safety, it is my third line option. Now, the treat and extend regimes are more proactive. It means more number of injections. So be careful. In our setup, it means a patient may have to shell out a lot more, but I believe is the safest option for one-eyed individuals. It's also a very good option for patients who are stable but not dry. And now the world is coming around to accept this, that patients who are stable and not dry need to be treated with a treat and extend and not keep on giving them monthly injections. Monitoring, but the difference is, I believe it's important to monitor every 4 weeks, even if the treatment interval becomes greater. So you monitor every 4 weeks, treat them with a treat and extend regime. The wait and extend is actually a way of monitoring and then extending in patients who become dry. And when they become dry, you can extend the interval between follow-ups slowly up to almost 3 months. But this is only after you have a lesion which is dry for 6 months or so. And this is possibly the best option for two-eyed patients in whom the lesion is dry. Now, how much can we increase the intervals between treatments? This depends on the drug you're using. The fluid study showed us that with ranibizumab, the average interval you can extend to around 7 weeks. The Altair study showed us that with aflibercept, you can do a treat and extend of up to 12 weeks in at least 60% of patients, and up to 40% of these patients can go up to 16-week intervals for the injection. That means 3 to 4 injections per year. With faricimab, you can extend to more than 12 weeks in 80% and to 16 weeks in 60%. So it's higher than that, but it's a much more expensive drug. And brolucizumab also can reach 12 weekly injections in over 50% of patients. As of today, aflibercept is my workhorse for patients with type 1 CNVM or type 2 CNVM who have multiple recurrences. Now, what is the algorithm I follow for management? All types of CNVM, you give them the 3 loading doses, month 0, 1, and 2, assess the response at month 3, and see whether the vision is stable or improved, and is the lesion dry. Now, if the lesion is dry, you have 2 options. You can either go to a treat and extend mode and increase the intervals slowly till you come up to 12 weeks with ranibizumab or 16 weeks with faricimab or with aflibercept. Or you can put the patient on PRN treatment. Now, except in myopic CNVMs, where you don't give a loading dose. In myopic CNVMs, you see and stop treatment if 2 consecutive OCTs have an identical morphology. So you gave the first injection, patient improved. Now you give one more injection. If there's no difference between this OCT and the next OCT 1 month later, you can stop. You don't need to give a third loading dose in this situation. Now, so this is a continuation of the same algorithm. So the lesion was dry. One-eyed patients, I would put on a treat and extend regime. The patient is two-eyed. I would prefer to have this patient monitor. We monitor every month for 3 months. and it stays dry for 3 months, you now extend the interval between follow-ups from 4 to 6 weeks, then 8 weeks, then to 10 weeks and 12 weeks. But 12-weekly follow-up continues lifelong in these patients. It will never stop. If a recurrence occurs, the patient gets a PRN treatment, and over a period of the next few months, you gauge how often are you needing this PRN treatment, and then you can put him into a treat and extend regime depending on what you see is the duration which the patient is regularly requiring the treatment. If the PRN treatment is with ranibizumab and it's less, you're giving the injection less than 8 weekly, consider changing to aflibercept. The second group of patients have received 3 injections and they are still not dry. They still have some fluid, but it's stable. Now you continue the monthly injection for the next 3 months. If it dries, follow the algorithm which I just told you previously. If it doesn't dry, this is the stage to now convert to a treat and extend regime, increase the duration between the injections and see whether at 6 weeks the fluid remains stable, then at 8 weeks, then 10 weeks, then 12 weeks. Whatever level it remains stable, you stay there. If recurrence occurs or increase in fluid occurs, you decrease the duration between the injections. Now, the important thing is that your initial 3 loading doses, say with aflibercept, which is now my workhorse, is followed by the treat and extend regime in patients who are stable but not dry. And if you can maintain this on greater than 8-week intervals, in 10 weeks, not bad. But if it's not reached, consider faricimab. And if that doesn't work, then only the last option is brolucizumab in only those patients who have both the eyes. I will not give brolucizumab in one-eyed individuals. So this sums up the further algorithm. One-eyed patient, you give treat and extend, you're able to extend beyond 8 weeks, continue with aflibercept. You're not able to extend beyond 8 weeks, go to faricimab. Similarly, stable lesion, not dry, treat and extend aflibercept, you can extend beyond 8 weeks, continue, you can't, go to faricimab. This is a combination of economics and good science. Now, this is just to show you an example. This was a patient who came to me. He had actually had initially brolucizumab, and he was one-eyed, and I said, I'm not going to give you another brolucizumab when you get the recurrence. I said, I'll try with eccentrics. I tried, it worked for 4 weeks, and after 4 weeks, he got a recurrence. This time I tried aflibercept, and again with aflibercept, after 4 weeks, I got a recurrence, so we gave him faricimab. And with faricimab, there was a resolution. 4 weeks, there was resolution, but by 8 weeks, there was a recurrence. So again, he received a faricimab, and this time, again, resolution occurred, but at 9 weeks, we got a recurrence. So I realized that 8 weeks is probably the most we are able to do. We managed to extend him, again gave the injection. This was again at 8 weeks. And the third time, again, we put him on this and managed to take him to 9 weeks. What I realized was that by converting from aflibercept to faricimab, we were able to go to extend the interval by 4 weeks. This is another patient whom we tried. Eylea was given, did not respond, and finally was shifted to brolucizumab, responded very well. And a second patient whom did not respond so well. This was on Eylea, got a brolucizumab, got a partial response. This is just to let you know, people who think brolucizumab is a panacea for all their ills, it's not. In recalcitrant patients, some 30% respond very well, complete resolution, another 30% show a partial response, and there's also 30% who don't respond. So when to switch? If you're on ranibizumab and you're getting recurrence in less than 7 weeks, switch to aflibercept. If you've got a stable lesion, not dry, and you're needing injections monthly to 6 weekly, again switch to aflibercept. If the patient is on aflibercept and you're needing injections more than once in 8 weekly, again consider a switch to faricimab if the patient can afford it. The same applies if the patient is stable and again you're needing 6 to 7 weekly aflibercept, switch to aflibercept. Brolucizumab I would only do if the patient doesn't improve with faricimab and the patient is two-eyed, and in that case too, I would not repeat brolucizumab in at least once in 8 weeks I will keep. I may 4 weeks later, if there's still fluid, give aflibercept. Now, just for those who say, hey, what the hell, yeah, they're talking about drugs which we can't afford. The good news is, long-term studies have shown, and this was a comparison of ranibizumab, aflibercept, and bevacizumab, that ultimately the difference did not come in terms of the injection. It came in terms of the number of injections. So no difference in outcomes regardless of which the drug was, no difference in OCT, but the difference was the more the number of injections, the more the time the injections continued, the better the visual outcome. So don't ever fret. Your patient can't afford faricimab is not the end of the world. He can't afford aflibercept. It's still not the end of the world. We have biosimilars of ranibizumab. Continue on that. And just to show you, this is a study from Switzerland where they gave ranibizumab, and over 7 years, giving injections at 4 to 8 weekly, they were able to maintain better than 20/40/612 vision in 43% of patients. They were able to maintain better than 618 vision in 2/3 of the patients. So the important thing is to continue and not to give up. My basic principle is I have no tolerance for fluid. Saying I tolerate fluid is like the fox saying grapes are sour. Intraretinal fluid, not tolerated at all. Subretinal fluid, tolerated if it's stable, and I can't remove it. Sub-RP fluid, don't run after. It doesn't affect your final outcomes. But any increase on fluid is not tolerated. Ladies and gentlemen, ultimately, aggressive treatment is the key. Monthly follow-ups are essential till the lesion heals, and then 3 monthly is lifelong. Greater the number of injections, the more intensive and longer the follow-up, the better the visual outcome. Initial PRN can be converted to later treat and extend regimes, but you have to have a very high index of suspicion for retreatment, any loss of vision, any new fluid, any macular hemorrhage. Therefore, fundus examination is equally important. And any subjective evidence of fluid, you're following up, you say, no, it's increased, give the injection. Eternal vigil is the price we pay for maintaining vision in patients with CNVM. And with this regime, even with the most economical method, believe me, you will get results comparable to what is quoted in the West. Thank you very much.
Excellent talk, Dr. Dinesh. Does anybody have any quick question? We'll just have a couple of minutes of discussion. I just want to put it in perspective. There was this fluid study which suggested as a shoot-off of the CAT study saying that perhaps you can tolerate a subretinal fluid up to 200 microns and it's beneficial. They went as far as saying beneficial. But please remember that the reason in real world we are not able to replicate the impressive results of clinical trials is because all of us tend to tolerate some amount of subretinal fluid. Also, to put in perspective, is in the CAT study, there was a clear thing showing that even with monthly injections, only in half the percentage of patients was the maculae completely dry. So there is going to be some amount of fluid. I think what Dr. Dinesh Salwar said is what we should not tolerate is any increase in fluid. And if there is persistent subretinal fluid, do not put the patient on a follow-up, even if you're using treat and extend beyond 3 months. Keep watching them, and if there's any new fluid or loss in vision, we should take care.
Thank you.
So I just...
Anand, after you, we'll have the keynote. So Anand is going to talk about his approach to center involving DME.
So I just wanted to ask, do you use Avastin or biosimilars?
But frankly speaking, I don't use Avastin now because of the problems which we have with cluster endophthalmitis previously,
Yes,
and also because their product information very clearly says, at least in the Indian one, that is not for eye use. So you are really putting yourself on the line.
Yes.
I use biosimilars. I use ranibizumab as a biosimilar if the patient can't afford it.
Yes.
But of course, if the patient can afford it, for me, for type 2 CNVMs, it's ranibizumab. For type 1 CNVMs, it's aflibercept.
Yes. Thank you, sir.
Okay, so thank you. It's a pleasure to be here at Dr. Lalit's symposium. This has always been a well-attended one. So I'm going to talk to you about center involving diabetic macular edema, principal paradigms, my approach. So the pathogenesis of DME, I think that's important to understand, is hyperglycemia is a prime driver, and by triggering a bunch of biochemical pathways, it pushes out a number of cytokines and chemokines. One and primary amongst this is VEGF. So when we are using anti-VEGF primarily we're only addressing this component, but see, there are a number of other players, and this is the reason why we have this component of refractory DME, which is significant to DME. And then by altering blood-brain barrier, increasing vascular permeability, you get a DME. So management of DME is evolved from laser photocoagulation in the 80s through the turn of the millennium, where we had Tricot and the current anti-VEGF conglomerate. Okay, so the management challenges are straight and simple, as well as the tough tackles, and I'll begin with the straight and simple. So the guiding principles gleaned from the trials governing DME management, first of all, we need to know what works. Then we need to know what works best. And then what works if the patient presents to us late. And then if we hit a wall with anti-VEGF therapy, what else can we work with? So what works? A bunch of trials are there which have unequally shown that anti-VEGF has high efficacy versus sham. What works best? This DRCR protocol T looked at the three main protagonists, aflibercept, ranibizumab, bevacizumab, and they showed clearly that aflibercept and ranibizumab had a clear edge over bevacizumab in terms of equity improvement, and aflibercept slightly better than ranibizumab at 2 years, and even so with macular edema reduction. So clearly, the two takeaways from this is that higher efficacy for aflibercept and ranibizumab over bevacizumab in patients with acuity less than or equal to 20/50, which is like 6/12 parts. If it's better than that, you can use either of these. And clearly, bevacizumab reduced macular thickness the least. Now, what do we do if you have chronic untreated DME, or patients that have been lasered for a long time and still there's a lot of DME? So this is a case where a middle-aged lady came in with chronic DME with severe NPDR. We advised anti-VEGF. Again, she defaulted, came later, and by which time it was PDR, and so we had to add PRP, and then ranibizumab. So over 8 months with 6 injections, she persisted with anti-VEGF, and you can see fairly remarkable resolution. So this tells us that acuity can be improved in untreated chronic macular edema with persistent anti-VEGF treatment. And this is borne out in the trials RISE and RIDE, which shows us that these ranibizumab arms, as soon as they were given ranibizumab, they take off. But you see the untreated arm, the sham arm, hardly gets off the floor. And then at 2 years, with 2 years of chronic macular edema, the moment they allowed ranibizumab treatment, that graph starts snaking up, equity improves. And the same was seen conversely with macular edema. Moment after 2 years of chronic edema, moment it's allowed ranibizumab, those maculae start thinning out. Another case where, again, a middle-aged male, diabetic, grid laser done, you can see those spots in the multicolor and the IR image. And then we advised anti-VEGF, again, patient defaulted, came 2 months later. But then once they were regular with anti-VEGF treatment over 7 months, you see that the maculae thinned out. And this also shows us that, therefore, acuity can be improved in lasered chronic macular edema with anti-VEGF treatment. And this is also borne out in clinical trials, where the RESTORE extension showed us that the two ranibizumab arms again took off, but the lasered only arm, the blue line, stayed on the floor. And again, after 1 year of chronic DME, the acuity started improving the moment they were allowed ranibizumab. And lo and behold, at 3 years, it caught up with the ranibizumab laser combination arm. So it tells us that A, don't hold by your hand if it's chronic. Go ahead with anti-VEGF. Number 2, it doesn't seem to make a difference whether you put that ranibizumab laser combination at the start or put in ranibizumab 1 year later after laser. At the end of 3 years, the one was the same. Also, the USP for laser, we think, is that it will reduce the number of re-injection rates. But this study shows that the number of re-injections is the same. So it's always not true. And up to 25% of the time, patients across all the treatment groups did not require ranibizumab injections. So what works if you're late with DME treatment? RISE and RIDE and RESTORE showed us that in both untreated eyes as well as laser-only eyes, it's never too late for anti-VEGF treatment, and chronicity is perhaps overrated. Also, adding laser doesn't always necessarily reduce ranibizumab retreatment rates. Now, what else works? What about lasers? What about the role of steroids? So protocol I looked at that, and they had 2 arms, ranibizumab with deferred laser and ranibizumab with prompt laser, and they showed that both of them are far better than laser-only eyes and steroid and laser. And in terms of acuity at 2 years, deferred laser was better than prompt laser at 2 years, at 3 years, as well as at 5 years, as well as in reducing central macular thickness. Now, this is a very important slide. So this shows that in both those ranibizumab combination arms, getting a fix on that DME very intensively in the first year, you see 8 and 9 injections, will dramatically reduce the number of retreatments you need to put in the subsequent years, so 2 and 1 and 3 and 2. So it's a beast that you need to get a grip on early, and it's important to tell your patients that, and up to 43% of patients required no ranibizumab retreatments in year 3. Also, issues of elevated intraocular pressure, glaucoma, as well as cataracts were only seen in the IVTA arms. So basically, the takeaways, ranibizumab laser combination was better than laser, better than IVTA laser. Deferring combination later was better than prompt laser. And early intense treatment, this is important, reduces treatment burden later. Of course, higher safety issues were seen for IVTA. Now, anti-VEGF regimens, the monthly dosing, we started off with that. Of course, we know it has best of efficacy, but issues of economic burden, not practical, infection risk time, etc. Then we graduated to PRN, which was strict, equity and OCT-based criteria. But then, even then, number of hospitals visits were more. So then we evolved into the treat and extend regimen, and the retain study was the first which compared treat and extend with the impressive results of PRN, and they found that the same results were kind of replicated with treat and extend. So that is something we can do. Now, when a patient sits in front of us, what are the guiding principles? What are the clinical factors that we need to look at? For that patient, in that eye, fundus picture, OCT, best corrected equity, but equally important, know the fellow eye status also, and then look at the systemic profile. So use this organized kind of nomogram, and then rule out masqueraders. Also, it's important to know that dosing history of the posology, what drug was used, what dosing strategy was used, was it adequate? And in our population, it's important to also know the patient factors, the compliance issues, financial issues around this patient. So these, on the right side is a list of mitigating factors where, equity is compromised because of RPD, generation, macular atrophy, etc. And I'll show you some examples. Here, when it's like that, you need not, you can desist from an aggressive treatment policy because, you're hitting a wall there. But if you have encouraging factors like this pure clean edema with or without subretinal fluid, suboptimal vision, which for me is about 618 to 4/60, you can pursue a more aggressive factor. So these are some of the mitigating factors: macular ischemia, subfoveal fibrosis, hard exudates in the macula, outer retinal tubulations, macular atrophy, and the surgical factors, vitreomacular attraction, and epiretinal membranes. Fellow eye, if there's good vision, you can desist from a very aggressive regimen, but if it's one eye, you might have to chase. Systemic factors that aggravate macular edema, like glitazones, nephropathy, hypertension, anemia, need to be watched out for. History of stroke, myocardial infarction, allergies needs to be asked for because you might want to step away from bevacizumab. So the first general treatment is monthly anti-VEGF injections until equity is stable, visual acuity, OCT is unchanged over 2 or 3 visits. If those mitigating factors I listed were there, then you can go for a wait or observe and extend follow-up up to 2 months. If those clean and encouraging factors are there, you can treat and extend. If it's stable, extend follow-up up to 3 months, or if it's unstable, go back to treat and extend. Now moving to the tough tackles. If the dosing is adequate and you've hit a wall, then you can switch it. You can move from a lesser one like Avastin onto Accentrix. And this is generally what we've seen, the patient refractory in Avastin, Accentrix. But please remember, I've even seen the opposite, where Accentrix has been given and Avastin has been of benefit. So it's not always true one way. And then the history is replete with articles where moving on to higher anti-VEGF like aflibercept as well as faricimab has helped for patients refractory to ranibizumab or bevacizumab. Now the million-dollar question is there a role for steroids at all in DME? So the MEAD study showed us that dexamethasone 0.7 milligrams did improve patients previously treated and refractory with laser or anti-VEGF treatment. So there is a role for steroids. And this is coming back again to that pathogenesis where I showed you those number of agents which are non-VEGF, which are drivers of DME. Now, this is a very interesting study from Korea. Huang has showed us the role of hyperreflective dots in identifying non-responders and taking that steroid option. So they found that hyperreflective dots were far more in bevacizumab non-responders than bevacizumab responders. And 75%, 3/4 of the bevacizumab non-responders responded to Ozurdex. And interestingly, hyperreflective dots are more in Ozurdex responders than non-responders. And that makes intuitive sense because we know hyperreflective dots are a marker of inflammation, microglia, molar cell debris. So therefore, there is a definite therapeutic role of steroids in anti-VEGF non-responders. But of course, you keep in mind the IOP and the cataract issue. Now, a head-to-head between an anti-VEGF and steroid. So this Bevodex study looked at bevacizumab versus Ozurdex. Of course, overall, bevacizumab did better, as you can see on the left panel. But then, when you take cataracts out of the equation, in the pseudophakic population, you see they're almost the same. And On the right panel, you see that Ozurdex gets a more swift response in reducing macular thickness. So it is a decent option in pseudophakics. The USP of Ozurdex is in post-vitrectomy DME. So very often when we are post-vitrectomy, we find DME there. So there is no other drug where the kinetics will not be changed by the lack of vitreous, like in Ozurdex. So in elderly pseudophakics, IVTA is possible. Why I say elderly is because in youngsters, the IVTA can cause a greater percentage of IOP spike. Ozurdex for vitrectomized eyes. Then the natural question, does adding steroids to anti-VEGF help? Is there a superadded effect? So DRCR protocol, you showed us that adding dexamethasone transdermal offered no significant advantage in terms of equity, but yes, in terms of thickness reduction, macular thickness reduction. Sohail and Wang showed that adding IVTA to Avastin offered also no significant equity advantage. Now, when we are treating DME repetitively, what we are not realizing and what is happily happening is that the background diabetic retinopathy is also, that rate of progression is reducing. So that's another effect. That's another, kind of an offer you can tell patients that, when I'm treating this, your background retinopathy is also benefiting. So in diffuse DME, combination is okay. And if you're doing combination, deferring that laser is a better idea. Also, the role for laser, focal laser, is still there in non-center involving DME. So please remember, don't dispel your laser machines. They're still valid in non-center involving DME. Epiretinal membrane, VMT, are surgical issues. Vitrectomy is required. Please keep in mind, ruling out masqueraders is important. And you need to look out for hypertension, MACTEL, and X-linked retinoscopy is a rare case, especially in young patients. This vertical palisading mimics DME. New laser systems, we talked about it just now, micropulse subthreshold laser. If we're part of that society and we are bringing out guidelines, the yellow 577 nanometer is very good. 5% duty cycle is what we profess. Contiguous treatment, you can paint that maculae. There's less RP damage, as you will see. There's hardly any signature on the autofluorescence and microperimetry. So I'll leave you with this last slide. We've also looked at, which is kind of summarizing everything put together. Other alternatives are increased frequency of injecting anti-VEGF, dose hike, dose cocktail, but I've really not found these of benefit. Future directions are subthreshold micropulse laser as an alternative to repetitive anti-VEGF therapy. Illuvine is something that's coming on, we'll be excited to see. Thank you for your time.
Thank you, Anand. Are there any questions from the House? Yeah.
Just to comment that once you reach the stage where you stop treatment for DME, don't forget to look out for PDR.
Oh, of course.
Because anti-VEGFs modify the
Sure.
retinopathy, and so you might land up with a bigger problem than you bargained
Yeah,
for.
of
So
course.
please don't forget that. That's the important thing.
A question for the House, including you. Question for the panelists, including you. Does Ozempic increase the rate of diabetic maculopathy?
I'm not very sure.
Ozempic, does that increase the rate of diabetic maculopathy?
I don't think we have clear level 1 evidence, but there's a lot of talk about that recently, yes.
Yeah,
I
so,
agree.
I think one of the I don't think it affects the macula. It affects one of the side effects of Ozempic is blurring of vision. Now that could be because of fluctuations in blood sugars, but also it's been associated with non-AION, so NAION.
Yeah, so two issues with Ozempic. This is I'm telling because this is now the topic for virtually everybody. One of the main risks of Ozempic, of course, is non-arthritic AION. And that is a scary thing. It occurs in 1% of people. So in case you have to advise somebody, you should keep that in mind. But the second important thing is, in patients who have diabetic retinopathy, non-proliferative diabetic retinopathy, Ozempic should be started with caution because it can precipitate increase in macular edema. So that's the group where you have to be careful. But in patients who don't have diabetic macular edema or don't have diabetic retinopathy, apparently it does not cause.
Yeah. I think the other thing that's going to come to the fore is in non-responders is the OCT angio, because that quite often you're hammering away and you've got enough macular ischemia to explain everything. So that would be one of the things that you could do in a macula that's not responding. If you don't have OCTA, well, just do a standard angiogram. At least you'll get an idea of central ischemia.
The other thing is that with faricimab, it's supposed to have a effect on astrocyte apoptosis. So it's possible that the neuronal changes that occur may be reduced in patients who are on faricimab, but that results we don't have just now. We don't have the actual
True,
results
it's
in a
not,
clinical
yeah,
studies.
borne by statistically
Yes.
significant results.
The
yeah.
experimental basis is there, but it's only after a few years we'll get to know. Yeah.
So I just wanted to ask, for a non-compliant, non-affording patient, will you advise vitrectomy for exudative DME? Non-compliant, non-affordable
for what?
patient. Vitrectomy for exudative DME.
So basically you're asking the role of, see, once you take the vitreous out, the standard which I showed you is where there is a tractional component, be it epiretinal membrane or a vitreous. That is the standard they're saying. Once you take out the vitreous, you must remember immediately all these drugs, if it doesn't work, it will work immediately, but if it comes back, it will work immediately simply because of the oxygenation that, that is more accessible to the 9 layers now. All right. But the fact is that you're removing the vitreous, and after that, you're only left with Ozurdex as a option. And the first thing you said is a non-affordable patient.
Yes.
After that, all your drugs will last only a few days. So then I won't recommend that. And of course, it's an invasive option. That's another thing you have to understand.
And if the
Yeah.
patient is non-compliant, then it's going to come back again. Systemic control is extremely important. If you operate, remove the exudates, they'll come back.
Yeah.
We now come to Dr. Nathan Verma, who's coming here from Australia, and he's going to give us a keynote address on high-dose aflibercept, real-world experience in DME and RVO. And after that, we will have Dr. Malika. She's going to talk about management, her approach to management of RVO.
Thank you, Dinesh and Malika and Anand. It's always a great pleasure, and it's like coming home, coming here. So, but I'm going to talk to you about my early experiences with aflibercept 8 milligrams. These are my disclosures, and also I'd like to thank Andrew Chang and Bayer for giving me some slides. Let's go back a little bit and look at the a few studies and what that showed us. When we talk about aflibercept 2 milligrams or Eylea, and then the new aflibercept HD or 8 milligrams, we find that there is an advantage using 8 milligrams in terms of durability and also potency of the injection. So you get good resolution, faster resolution, and longer intervals between injections. And so that means there is an advantage of using a higher molar dose. When we look at the extension, which means what happens after this formal study is over and then you go on to 156 weeks, and then those people comparing 2 milligrams with 8 milligrams, when at the switchover at 96 weeks, if you switch from 2 to 8 milligrams, it certainly does provide an advantage to those groups those people who are in the lower dose group. So switching from lower to higher does give you an added advantage in terms of reduced number of injections in the extension period. This is also seen in the in the central retinal thickness. So this is really about patients with AMD. As you go along with year 3, year 5, the number of injections reduces. This is something that we're quite familiar with. When we go on to DME, which is the photon study, now the difference between standard loading doses with aflibercept 8 milligrams, when the studies were done, they used only 3 loading doses instead of 5. So it was the same way as you would do for AMD. And you'll see that the switching also allowed lesser injections in the 96 to 156 week mark. And also this was good for the central retinal thickness. What you see here in the yellow part of the graph, which is on the left, you see that there's a sort of a seesaw pattern, and then that tells you that the drug action wears off, then and so it goes. Whereas when you use a higher dose, not only do you get a quick reduction in the central retinal thickness, but you also have less seesawing, so there's a lot of less fluid moving in and out, so that's telling you about the durability. And again, in these patients, the number of injections falls with time. So now I just share with you a few patients of my own. And look, we just got access to Eylea HD sort of middle of last year. This is the first year, so the first 2 patients are ones who just started treatment with Eylea HD rather than switching. Here's a patient who was first seen on the 16th of January this year. He had bilateral diabetic non-proliferative diabetic retinopathy with maculopathy, slight reduction in vision. He responded on the left side, as you see, within 3 injections. He's almost got a complete resolution of his edema, and a similar story in the right eye. So here you see that you get in this particular patient, he was well controlled, good model sort of diabetic control, good response very early in the piece, and there was no change in the intraocular pressures with time. Here's another lady with AMD who came in, commenced on high-dose Eylea, and you can see that in August 2024, and she had then 2 months later complete resolution of fluid, and that has stayed, allowing us to extend the intervals to 8 weeks and then 10 weeks and 12 weeks. So she's on that phase now. We follow a treat and extend to move her on, and that's her intraocular pressure showing that even a higher dose makes no difference. A last patient who came in with what seemed to be a polypoidal vasculopathy, it's a 70-year-old female with visual acuity of 6/36. That's her fluorescein angiography and her ICG, and you can see her OCT quite clearly. She was started off on aflibercept 8 milligrams, and then we were able to increase the gap between injections to 8 weeks pretty quickly, and she had a good response. So, and you can see that also on the fundus photographs where the macular bleed is beginning to settle down. So we have a study called the CURIOS study where each center is analyzing 10 patients of their own and looking at how they responded to naive patients and also patients who were switched. And we find that there's a significant visual acuity and reduction in central macular thickness after the first injection. So look, these are very early data, in fact, only from one center, but that's the feeling you get after you analyze and see what's going on. So that 70% of patients achieved greater fluid control after just one injection of the drug, so telling you that the potency is much higher. And PEDs also, which are sort of often don't respond to anything, seem to work quite well here. So patients really have a potential for quicker extension with the new medication. Now, if we come to patients who were switched, so this is a patient who was on faricimab and was not really responding even at 4-weekly injections, and then you can see that she just carrying on, and then we switched her over to aflibercept 8 milligrams, and then slowly within a month she settled down, and then we started the extension to 6 weeks, 8 weeks. So we normally do 2 weeks at a time, so showing you a good response. Another patient who was on 2 milligrams for a long time, but is a retired doctor, wanted, saying, look, I can't come so often, do give me something else. He wanted to extend. So here's a patient who was stable on aflibercept 2 milligrams and then switched over to 8 milligrams, and we are now in the process of extending the interval to 9 weeks. So he was on 10 weeks, so if it's on 2 milligrams, 10 weeks, we go to 8 milligrams, 10 weeks for a start, and then start the extension from there. So that was the right eye. This is the left eye, showing you that one can switch quite clearly. Another patient who has been through the whole pharmacy, she was on Eylea 2 milligrams from December 22 to August 23. She had a slight reduction with Eylea 2 milligrams, and then slowly the fluid started coming back. Then we switched over to faricimab, again, slight response, and then back again. We're not talking about extension, we're talking about response. She says, doc, all my patients, all my friends are on Eylea 2, let's try it again. So I said, I don't mind, let's go back. So we tried, and again, not much difference there. So she was humming along, vision maintained, but as you said, the SRF doesn't go. The fluid study shows that SRF we can tolerate, but what's better than having SRF is not having SRF. So we then switched over to 8 milligrams, and she did respond, and now we're in the process of extension. So, and that's her intraocular pressure. Here's your horror diabetic patient. He's a truck driver, poor diabetic control, sits the whole day, smoking, and you just look at him walking in and you say, that's a bomb walking through. This is going to be a difficult one. He's had PDR, for which he was started on Avastin, and while his laser was going on, and then he sort of left him on Avastin for his DME. Then slowly Avastin stopped working, said, okay, doc, that was, let's start with Lucentis, and then Lucentis worked for some time, and then he ran out of control there also and said, all right, okay, let's switch to Eylea. And so he was on Eylea. It worked for a little while, and then again stopped working. Although I must say he stopped smoking also. His biochemical control became better. He lost some weight, not too much. And then we switched him over. You see the first two OCTs on the left. These two are, he's still running on Eylea. And then we switched him over to Eylea HD, and he's had a pretty good response. So he's been treated since 2011, and that's his intraocular pressure right through. So really, when we see that in this group of patients, when we upgrade, these are the group of patients who we upgrade to aflibercept 8 milligrams from some other drug, although most of them were switched from 2 milligrams to 8 milligrams. And the reason for the switch was the idea to try and extend, although a third of them, a third of them was to do with the idea of extension, but most of them weren't getting a handle on the disease activity. And we found that one could actually keep the anatomy and visual acuity at least maintained, and found that there was a good response to switching even after one injection, as we saw in the naive patients. So, these are initial days, but we don't have any safety concerns. The one concern that did come up was you're injecting a larger amount of drug, 0.07 rather than 0.05. Does it make any difference to the intraocular pressure? 30 seconds after the intraocular injection, the pressure in the 8 milligram, which is the larger volume group, goes up, but then by 15 minutes, it's down. So this is a Swiss study, and our own study was very simple in our own thing. We took pressures at 1 minute, and they were between 38 and 57 millimeters of mercury, but by 20 minutes, it was all back. So no real concerns about intraocular pressure. And all of us who've used, Kenacort or Triamcinolone injecting 0.1 mil, we really never thought of all these things. So I think when aflibercept 8 milligrams becomes available, its increase will be good in terms of using for DMO, for AMD, and then past the Quasar study for retinal vein occlusion. So that's where we are. So greetings from Tasmania. That's Wineglass Bay. So if you come there, this is kind of scenery you get to see. But thank you for your attention.
Thank you, Dr. Nathan. Any questions for him?
So I have one. Dr. Nathan, with the high dose, 8 milligram, the volume is not so much of an issue, but we're injecting that many more, drug molecules. Yes. Is there any concern about in AMD patients with a bit of, attendant geographic atrophy? Can that, with repetitively putting such a high dose, can that, accelerate the atrophy? Because this is something I asked this because in the CAT study, again, hopping back to that, we saw that the amount of geographic atrophy was more in the Lucentis arms, and especially monthly more than PRN. So is that a concern?
Not as yet.
Okay.
But, this thing is now going to, when you're talking of real-world experience, that's when the atrophy came out. It didn't come out because that takes time to come up. But, I really don't know the answer. You're dealing with a devastating disease, which is progressive. So the first misconception is that when you treat neovascular AMD, that it comes to a standstill. It doesn't. It just slows down. And atrophy is just part of the process of advancement of the disease. Whether it accelerates or not, I don't think we have the data.
We have the data. Okay.
So even in the CAT study, the association was not causative.
Yes.
So
No, it is not causative, but the p-value was significant. There was a 25% difference
but that
between
could also
Lucentis monthly as well as Avastin monthly. So about, once you get a grip on that disease, maybe should we step off a high dose molar concentration to back to regular, because you see the equity difference was not much. The only benefit was in the durability. So we have hit a very high bar with efficacy. So durability is now what everybody is looking at.
So to back your statement further, actually, if you see the VIEW trials, in VIEW 1, the results are uniform that 2 milligram 4 weekly is great. But if you see the results of VIEW 2, which has Asian patients and Indian patients, the results of 2 milligram 4 weekly is the worst in terms of visual outcome, but not in terms of drying of the lesion. So seeing the combination, lesion dries, vision does not improve, actually gives me an idea that maybe there's more atrophy in Asian patients with too much of aflibercept. And they got better results with 0.5 milligrams. So with 8 milligrams, It's possible that maybe in Asian patients it will show up before it shows up in Caucasian patients.
No, I think these are things that time will tell and nobody else can. Yep.
Okay, so now we have, after this, we have Dr. Malika. She's going to be talking about her approach to retinal vein occlusion. And in the meantime, if there's any other question anyone wants to ask. Babu, you're quiet for a very long time.
Dr.
We were
Verma, I
expecting
would-
you to ask something at least.
Yeah, I was wondering
And Naresh?
from the few cases that you showed, was your experience better with this 8 mg than with faricimab? Would you say that on the that's a better or a more efficacious drug, and also duration?
I don't look. The sequence of events was that we got faricimab before we got Eylea 8, and anyone who's stable on faricimab, there's no indication to move them to Eylea 8 in any way.
Yeah.
So in terms of equivalence, you look at two things: initial response, which means how soon you can get the the anatomical parameters better, and the durability. I have a feeling, because I had more patients on Eylea, I just switched them straight to Eylea 8. But I think this question as comparing A with B in the real world, maybe, where's your next AIOS?
Jaipur.
I might have something more than at that time, but right now I don't know.
Okay. Because that's really the most important question for us is whether it's better than faricimab. Can we start the slide? There's some more questions. Yeah, one more question for Dr. Verma.
Look, have you done PDT? Have you ever done PDT? No. Okay. If you wanted to see rips, that's when you used to see rips. Those were the real rips. But once we come on to the anti-VEGF era, it was so bad with that time we were scared of doing PDT in patients with PDs. But with the anti-VEGF agents, the rips are actually very, very uncommon. And same thing with Eylea, whether it's 2 milligrams, 8 milligrams for faricimab. I don't think there's any worry about rips.
Incidentally, it's going to take time for you to see rips because most of these patients are shift patients. And usually rips happen in the first injection or two. So a patient who's taken up who's been on aflibercept and is now shifted to faricimab or high dose is unlikely to get a rip.
There is no propensity for any.
At that stage, it goes away.
Yeah.
All right, I think time is it? Okay. I'll be speaking about my approach to retinal vein occlusions. It's not moving. The
Slides are not moving.
page down, it's not moving.
It's like a painting.
Okay, okay. So we look for, when we see a patient with retinal vein occlusion, most important to look for these systemic 4 major comorbidities and address these, otherwise there is no point in local treatment. And in younger patients to look for inflammation, homocystinemia, blood malignancies, antiphospholipid antibody syndrome, and very importantly, medication like oral contraceptive pills and sildenafil. So unless we look at this, there is no point in starting injections. Very important ocular comorbidity is glaucoma. It's the chief ocular comorbidity with our retinal vein occlusions and can be missed very easily. So look at the discs very carefully bilaterally. It could be the other disc which gives the diagnosis. Once we know that it is a glaucoma patient, we start treatment for glaucoma and we try to avoid injection intravitreal steroids because that would increase the IOP. As well as when treatment for glaucoma starts, we request the glaucoma physician to avoid prostaglandin analogs and alpha agonists which can increase the incidence of macular edema. I've also found by patients with papilledema coming with vein occlusions in their subsequent visits, probably because of external compression by the disc edema. Now, retinal vein occlusions can be classified based on their location as central and hemiretinal superior or inferior, or one of the branch retinal vein occlusions. And the central and hemi can be ischemic or non-ischemic, and the branch can be major or macular branch vein occlusions. One of the most common is the non-ischemic CRVO and HRVO. They present as macular edema, which is generally well responsive to treatment, may be recurrent, but generally fewer injections than the ischemic variety, and good visual recovery. This is how they present, and generally good visual recovery, though recurrent edema is there. Ischemic CRVO and HRVO present with much more severe vision loss, extensive hemorrhages, maybe massive macular edema, or even absence of macular edema but severe ischemia. And the vision remains poor even after the macular edema resolves because of the ischemia. So this is how they present. Even with the injections, the vision remains poor. But more importantly, in these patients, we have to be vigilant for iris new vessels and neovascular glaucoma, which can be a painful blind eye. Hemiretinal vein occlusion, in terms of proliferative complications, behaves like CRVO because of the larger extent of involvement and ischemia. In terms of macular edema, it behaves more like BRVO. So in these two, CRVO, HRVO, vigilance for iris new vessels, angle new vessels, highest risk used to be in the first 3 months earlier. But now, because anti-VEGF injections are given, the risk actually starts when the anti-VEGF stops after 1 year, 2 years, or 3 years. So the risk for new vessels, neovascular glaucoma can be much later. And even the non-ischemic cases are not safe. Often they progress to ischemic CRVO and go into NVG. So once you see a CRVO, they are not safe. For life, they are not safe. They have to be monitored for NVG. Branch retinal vein occlusion can have multiple macular complications, which I have listed here. Most common, of course, is the cystoid macular edema, which requires repeated injections, but hemorrhages can also compromise vision. Often, chronic edema develops ERM, which compromises vision. Even with treatment, sometimes they can go into macular hole because of the edema, with poor prognosis, and presenting with macular hole, ERM. And another interesting feature of branch vein occlusion can be macular exudates, which ultimately cause irreversible vision loss. So they seem to appear when there has been long gap in treatment or a neglected case. And they also need more intensive intravitreal injections for resolution, more frequent, more number. And alongside is very important systemic control, especially the lipid control, but also diabetes and BP. So I would say prevention of this foveal center is very important, because once they come, even resolution may not ensure good vision. It causes some permanent damage. So these are patients where neglected initially, and then resolution with injections can happen, but vision doesn't improve. Once you have had center involvement, vision remains poor. This is a patient who did not have any treatment in the first 2 years despite counseling, so then came with massive exudates, and then we could resolve them with intensive treatment. However, not every case will resolve. Here we have tried all medicines. Initially, there was no treatment for 2 years despite counseling. And then we have, when he agreed after 2 years, despite even using all drugs, including faricimab, there has been a recalcitrance. And the vision remains 660. Also, BRVO presenting with macular ischemia, no edema. Here, there is almost no macular edema, but there is hard exudates which are going into the foveal center, approaching. So we treat here just to prevent the exudates coming into the center. That's what I do. I prevent exudates coming into the center so that we can retain 6/6. Proliferative complications with BRVO also common. You see silently sitting NVE, NVD. So annual retina exams for a BRVO is very important, for any RVO, but also BRVO. And if you see these new vessels on the disc which are silent, you have to start immediately. Scatter laser, which can be just over the involved quadrant, or it can be a pan-retinal laser sometimes required, because new vessels do not regress with just sector scatter laser. So it may become a all quadrants pan-retinal photocoagulation. So annual review is very important for these silent new vessels. And here the patient has presented directly with NVD and vitreous hemorrhage in a BRVO which was otherwise asymptomatic, no macular edema. So BRVOs can also be deadly. And here post-laser, pan-retinal photocoagulation was required. Ultimately, the new vessels regressed. This again, they can present with vitreous hemorrhage. It's just a BRVO with ischemia at the macula requiring surgery. And now at least extensive scatter laser. Macular BRVO does not suffer from proliferative complications because it is a smaller area of involvement. However, the macular edema can be very recalcitrant, persistent, and they may not always have a good visual prognosis. RVOs may start looking normal over time, but if you compare the two eyes, you can see the tortuosity. If you see the octa, you can see in a branch vein occlusion, you can see the affected area. Imaging is multimodal, OCT being the cornerstone, but also fundus photography, OCT angio and fluorescent angio. You can see that OCT shows not only edema, but it also shows ischemia. And photography, if you see over 5 years of treatment, the edema looks the same. So if you were following only with OCT, there is no treatment, no benefit. But if you see the photographs, the hardy exudates have gone. So there is benefits to photography. Angiography shows ischemia, new vessels, collaterals. Fluorescence still holds a place. For example, this patient came to me after several injections elsewhere, but he still didn't have a diagnosis. They were treating him as possible macroaneurysm, succinate retinopathy, BRVO. So just one fluorescent and we got the superotemporal hypoperfusion showing BRVO. So now we have a diagnosis and we also know where to do the laser. The grid laser has to be applied superotemporally. Similarly here, a patient presenting like this, fluorescence shows that it's an inferotemporal BRVO with leakage, so this is where the laser has to be applied. So fluorescence has a very important role in many cases, and also can pick up new vessels where their view is poor, even new vessels on the iris showing leakage on the right side. Treatment for all macular edema is and serial anti-VEGF injections, and secondary role is laser, steroids, vitrectomy. Anti-VEGF agents give very good results, and these are the agents available. Steroids are second line and not preferred because of the two complications, but also DEX implant, we have to be very careful when we use in patients who have a large PC opening or a scleral fixated IOL. This is my own patient, the second one from the right side, where it migrated into the AC, causing an emergency IOP rise and corneal decompensation. When to consider steroids? So this is only where anti-VEGFs may be contraindicated, such as in pregnancy, recent cardiovascular events, severe renal dysfunction, or where there is traction which can worsen with anti-VEGF. Macular laser for BRVO, just like DME, not very, very desirable, but may reduce recurrences. For CRVO, there is no role for macular laser, but of course pan-retinal laser. Follow-up of patients with retinal vein occlusion every 6 to 12 months is mandatory with undilated slit lamp exam for new vessels on the iris and angle. And fellow eye involvement is very important. Over every year should be checked. Silent RVO in the other eye is very common. You see this patient presenting with one eye, but you see the other eye also has macular BRVO. And they can even go into proliferative retinopathies silently. CRVO, when it presents with a disproportionately poor vision, often there may be a cilioretinal artery occlusion seen as retinal whitening, which can be picked up on the OCT angio. And this is the last slide, retinal vein occlusions in young patients, generally very good prognosis, may not need any treatment, but if required also generally one anti-VEGF injection is enough. The causes are inflammation, idiopathic, blood dyscrasias, or more often medication. Thank you.
Thank you, Malika. I think she made very important points. First of all, you have to consider the younger patients and older patients separately. The younger patients, you have to look for a systemic cause and treat the underlying pathology. In the older patients, is usually not any other cause other than maybe hypertension or glaucoma. The other important thing was about the macular BRVOs, which are actually quite recalcitrant to treatment. Though they look like small problems, but they are recalcitrant problems. So that's the other important thing. Third is the role of laser, especially don't miss out extensive areas of capillary non-perfusion, especially in BRVOs which are requiring too many injections. There, laser could make a difference, in addition to the focal laser, which you may do later on. So these are some of the points which are very important. Any questions from the house or from the panel? Yes.
Initially, if you are neglecting, these will become
Chronic.
So we should stress on appropriate management of tributary BRVOs with macular edema. That is one important. The second is CRV with macular edema. Again, it's very, very resistant disease, and we should have an open mind for n number of injections. And maybe if it is required, you may have to add some photocoagulation in the periphery to facilitate or to reduce the number of injections as well.
Yeah, the other important thing is CRVO is a serious problem, a much more serious problem. BRVO is you can afford to be a little more comfortable in taking care of the patient. So don't be as aggressive in BRVOs. You'll just end up giving them injection after injection without getting any gain. So you also have to see what is the gain you're getting by giving very intensive treatment versus a more conservative regime. So keep that in mind when you're treating these patients.
Specific to RVO, I find multiple RVOs are very common. In the same eye, you may have 3 areas and the other eye 2 areas of BRVO, or silent RVOs, very common, which can lead to silent proliferative retinopathy, and they come with a disaster in the other eye while you were focused on the one eye.
Yeah, which is why the role of fluorescein angiography at least once
Or
in
at
a-
least careful exam of both eyes at every review.
So with that, we now come to the last lecture for today. That is Dr. Avninder Gupta, who is going to talk about his approach to extra large macular holes. As Lalit said, we've all talked about small holes, but what we see more often are the bigger ones. So let's see how to manage them.
Thank you, sir, and good morning, everybody. The basic concept is ki with all of us, ki if you have a large macular hole, then this cannot be operated. You will not get any kind of results. But with this technique, with the advent of newer technique, we are able to close these holes with a decent gain in vision. What a large or giant macular hole is defined as base macular diameter of 1000 microns and MLD of 800 microns. These holes have high rate of failure, and the failure rate is in between 650 to 1416 micrometer is between 19 to 24%. If you look at the close classification, which is a recent classification, according to the size, the classification has been given. Large macular hole is between 400 to 650 microns. Extra large macular hole is 650 to 800, and large macular holes is 800 to 1000. And above 1000 micron, we label it as a giant macular hole. And with the advent of OCT, we can measure this and we can prognosticate our patient. These are the management strategies for large giant macular holes. So our concept is to provide a scaffold with an inverted flap or an ILM graft, and retina is made elastic by detaching it in macular arcade. Now, if you look at this patient, it's a giant macular hole. And if you look at the base diameter, it's somewhere around 1100, and the minimal diameter is 800 microns. So we go ahead with the surgery, which is with ILM flap with macular hydrodissection. Once you do an posterior vitreous attachment, and the ILM is stained with the BBG dye. Then a rip is created with the help of a diamond-dusted membrane scraper. And since I want to make an ILM flap 360 degree, a good flap is important for the closure of the macular hole. So I create this 360 degree rip with the help of a diamond duster, because with this technique, I'll get a very good macular flaps. The rip, I continue on the temporal part, and you can see here, almost 360 degree, I have created a rip in the ILM flap. Once this 360 degree rip is created in ILM flap, I take hold of the forceps, peel the ILM, and you can see I have to peel this ILM and come just near the whole macular hole. If I go beyond this, my flap will get dislodged and I'll get a free flap. So you have to peel this macular hole till the edge of the macular hole. That should be very clear. Once this peeling is complete, you decrease the suction of the cutter to somewhere around 50 and trim this flap. Since it's a large macular hole, so what I do, I prefer to create a macular detachment. This is a 40 gauge needle on a 23 gauge cannula, and I reduce the PSI and inject BSS in the macular area. You can see here the blister, but still the detachment has not gone up till the margins of the macular hole. So this detachment is increased, and once the detachment reaches, that means I have created an elasticity in the retinal tissue. Similarly, I have to detach the inferior part also. You can see the blister here, that starting a detachment, and I can tell you it's not easy to detach an attached retina. It's very easy to say कि retina detach हो गया, but detaching an attached retina is difficult and it takes time. Once procedure is done, I go ahead and do an fluid air exchange, and you can see the post-operative results. This is 2 weeks post-operative result. The macular hole is closed, and this patient improved from finger count to 624 vision. This is another patient, and I started this technique with this patient. You can see a silicone oil filled eye, almost a square-shaped macular hole. The chances of closure are pretty less. So what I do, I go ahead, remove the silicone oil, put BBG, and create and rip an ILM flap, and then an ILM flap is created. Once the ILM flap is created, the flap is then trimmed, and I aspirate the subretinal PFCL from here. And what I did, in a mistake what I did here was I started detaching from the infratemporal quadrant. So once I start detaching from the infratemporal quadrant, that detachment extends to the infratemporal part of the retina and the macula does not gets detached. So again, I go here and detach between the disc and the macula, and I then create an macular detachment in this area. And you can see the post-operative result. These are the post-operative results. Patient improved to 636 vision with a very good closure of the macular hole. This is one of my patient. You can see it's a pretty large macular hole with a base diameter of somewhere around 1800 microns. And already ILM peel has been done. These are the margins of the ILM peel which has been done. So what I do is I create an ILM hinged flap nasally. Then I put a PFCL and then drag this ILM flap into towards the macular hole and stuff this macular hole with an ILM flap. Then under bimanual irrigation aspiration, with one hand I am removing the PFCL, the other hand I am putting a colored BBG dye or viscoelastic. Because of the current of the fluid, this flap can dislodge, and then I create an macular detachment in this patient. And this patient, you can again see the vision improve to 624. This is one of the patient of square-edged macular hole. We did a similar procedure, vision improved from 660 to 612, and you can see how beautifully the macular hole is closed. Another patient, traumatic macular hole, a very large macular hole. This was a young patient. We used silicone oil as a tamponade, and again this patient improved to 624. These are my 9 patients, what I have done over a period of 2 years, and each and every patient had an improvement in visual acuity and a closure of hole. Various techniques has been described for failed, recurrent, and giant macular hole: inverted flap, autologous ILM transplant, lens capsule transplant, neurosensory retinal grafts, amniotic membrane graft, retinotomies, and hydrodissection. So what I do in these cases is I do an autologous ILM transplant with an hydrodissection. So the basic concept is I combine 2 techniques to get the best of the results. Up to 39% of chronic macular RDs have been reported to have adhesions between the retina and the RPE, contributing to difficulty with hole closure. This gives square-edged appearance on OCT in contrast to puckered edges seen in acute macular holes. Advancement of macular tissue by increasing the elasticity of the ILM peeling, scaffold over the macula, and macular detachment results in improvement in vision in almost all the cases. Vision improvement in all cases can be done in traumatic macular hole. Procedures like retinal grafts and retinal refining does not result in vision improvement. Although with the retinal grafts, you are able to close the hole anatomically, and you can show on OCT that yes, the macular hole is closed. but vision does not improve in all these patients. With this technique, I am able to get a lot of vision improvement in almost all my patients. The advantage of this disadvantages, I have done only 9 cases. Need more giant macular holes to come to conclusion about the effectivity of this technique. Thank you very much for your kind attention.
Thank you, Avnendra. So after you've done the detachment, you leave it under oil or you leave it under fluid, under air?
Gas.
Or gas? Okay.
Yeah, excellent technique, Dr. Avnendra. Just as a modification or an alternative to this, what I usually do is, as he showed these, it's not just large macular holes, it's large chronic macular holes, some of them that he showed, that makes it even more challenging. And what happens is these edges, why they are square is, the RP there is also a little damaged and they have got adhesions. So, detaching those and freshening up that area is a little important. So as a opposition to this, what I do is, instead of creating multiple areas of punctures with the 40 gauge, I sometimes use a cutter and just use a gentle reflux at the macular hole side, because it's a large one, not going and damaging the RP directly, but with a little reflux, that little edge will just open up like a flower bit. And then what I do is, as opposed to a single flap, I would do multiple 360-degree multi-layer flaps over each other. So what this does is, it's not what all these inverse ILM flaps do is, they offer a scaffold for the natural progression of this coming together centrifugally of the edges. So that plus that little detachment and clearing of the debris there helps in closure. And again, I use long-acting gas in these cases, C3F8 rather than SF6, and I've had similarly.
So what I
very good
find is
results.
that in these very large holes, and very often these are myopic holes, see, basically in any macular hole, it's a capillary action which is keeping the retina attached to the underlying RP. So if you just gently brush it, even with an old, very old diamond dusted scratcher, and you basically have to remove that capillary action, they will start opposing each other. Once you see it's opposing each other, what you'll see is, in very large holes, there'll be some gap left over.
It's a macular massage, or the
It's
massage
a very
technique.
gentle
You could do it,
massage
yeah.
with a silicone tip,
Yeah.
and then you see that there'll be some defect still left over. In fact, if there's no defect left over, you don't even need to bother about all this. It will definitely attach. The macular hole will close. But if a little defect is left over, that's where these multiple ILM flaps come. And I would actually, in these situations, prefer to put silicone oil.
Okay.
Because by silicone oil, the risk of that flap moving later on goes down.
Gas
the
has
only
a
thing is,
better
gas has a
tamponade.
very
Gas
good
has a
tamponade.
better,
Yes,
It's a
but-
stronger tamponade. I would just, for this very same thing, to address this, instead of oil and doing another surgery later, I would put viscoelastic. So that stabilizes that. If you're worried that so when they are hinged, they will never displace. That is one. But if you are, even he showed one thing about the free flap. So I don't like using
They don't
PFCL,
stay.
because when you're removing that PFCL, the flap can go off.
Yes.
So what I would do is, if I'm doing a free ILM flap, I would get the flap, okay, bring it under PFCL, but then put visco there, stabilize it with the visco, and then it doesn't matter, you can leave the
Anand,
visco.
what I did was, with one hand, I was removing PFCL and I stabilized the flap within viscoelastic.
Yeah.
But
See, even visco
until-
is not foolproof.
Yeah.
yeah, it's not foolproof, but
other-
that is the only way where we
See,
can stabilize
the problem
the
is
ILM
a
flap.
hinge flap, which is hinged on the periphery part of the retina, is not hinged on the hole.
Maybe hinged at the hole
has
only.
a tendency to move off. But if it's hinged on the edge of the hole, those stay where they are.
They always
So the-
hinged at the, so you're
Yeah, but
flipping
if
it
you have
towards the
if
whole
you,
side.
that area has been removed and this is a recurrent hole,
Recurrent,
then
yeah.
you have to hinge it from the
Then
peripheral
it's a
retina.
free flap, then it's a
Those
free
have
flap.
a tendency to move off, and silicone oil holds it better.
Okay, I'll just add a word about additional agents that can be used, because these all techniques are very traumatic. Inverting the flaps and these coming out, again you're going in, massaging, bleeding, and you may cause a lot of damage. So less traumatic would be to put in fibrin glue over that area, though personally I haven't done it, or platelet-rich plasma, which I have recently started using with very good result, platelet-rich plasma.
Yeah, one patient I did a fibrin glue, but it happened to fail after that.
Yeah, that's true. So
uh,
I have not used it myself.
I happened to use
So-
because I had a glue in the OT, so I thought I'll put a
So,
fibrin glue, but it didn't close.
I think, as you can realize, this is a controversial topic. Lots of ways of doing the procedure. all of them work anecdotally, but long term, we still don't know which is the best. So you've got a lot of thinking to do. With this, we close this session. Thank you very much for all of you for being here. Your presence has made the session successful. And Dr. Lalit Verma, I think, had designed a very well, it was a very well designed course with very important topics, and I'm sure you enjoyed it. Thank you very much.